Greetings, everyone, and welcome to the EKG case for the week of October 7th, 2013. This is Amal Mattu at University of Maryland, and this week's case was sent to us by Dr. Giuliano Deportu. Giuliano actually sent this case to me almost a year ago. That's how backed up some of these cases are, and I was going through the files looking for a case for this week, and I came across this week. It's a great case to discuss. And actually, a year ago, Giuliano was an ultrasound fellow at the University of Florida when he sent this. I'm not exactly sure whether he's still doing an ultrasound fellowship now and where he is, but Giuliano, if you're out there, thanks so much for sending this case, and please send me an email, let me know where you are now. Anyway, this case was a patient that he took care of. It was a patient who was apparently found down at home, an older patient, and the patient was brought into the emergency department supposedly as a trauma alert. So the presumption was that the patient had fallen and suffered some type of head injury or some other type of injury. Nobody really knew for sure what was going on. The patient was intubated prior to arrival, and Giuliano saw this patient along with the trauma team, and he looked at the 12-lead EKG, and to him, the diagnosis was very apparent. And he voiced his opinion to the trauma team, and they all thought he was crazy. But it turned out that he was absolutely right. So let's talk about what it was that Giuliano saw on this 12-lead EKG. There's two major findings that hopefully just jump out at you. Number one, there's big T-wave inversions in a lot of the precordial, and in fact in the inferior leads as well. Big time precordial T-wave inversions. And I don't know if an old EKG was present or not, but presumably these are new big T-wave inversions. Some people might say those are so big that they are almost have the appearance of a roller coaster. I can't draw a roller coaster, but anyway, that's something that I learned we refer to back in residency as roller coaster T-waves. And I was taught that term by a real EKG guru by the name of Edward Chung at the Thomas Jefferson University Hospital in Philadelphia, one of the guys who really taught me a lot about EKGs. And so keep the roller coaster term in mind as we go through this. And the other thing that stands out as very abnormal about this 12-lead EKG is the fact that there's a fairly prolonged QT interval, or even if you correct it, there's a very long QTC. So there's the two major abnormalities. There's your roller coaster looking T waves and also a prolonged QT interval. Those are the two main things that we will talk about this week. So quick, let's go through some differentials. First of all, causes of T-wave inversions. A couple of people have emailed and asked for the differential, and so this is a great time to talk about the differential of T-wave inversions. Now, this is probably not a comprehensive list, and unfortunately there's a lot of things that can invert those T waves. But there are a few points that we can make which are important. First of all, there are some leads which normally have T-wave inversions, and you don't need to do anything about that at all. It's completely normal to have inverted T waves in lead AVR and V1, and oftentimes you may also have an inverted T wave and or a Q wave in lead 3 or in AVF, okay? And I emphasize the term or. If you see it in both lead 3 and AVF, then that's concerning. You'd worry about ischemia. If you saw Q waves in both of those leads, you'd worry about a previous inferior wall infarction. But you are allowed to see a Q and a T wave, one or the other, in lead 3 or AVF, one or the other. That's a freebie. You're allowed to have that. Okay, so first of all, I guess it's useful to know which leads is it normal to have T-wave inversions, and those are the leads that it's perfectly normal to have T-wave inversions. All right, we've talked about this before as well. This concept of the fact that kids oftentimes have T-wave inversions, especially in the precordial leads. And young women up to maybe 40, 45 years old, especially African-American women, have a tendency to have what we refer to as persistent juvenile T-wave pattern in V1, V2, and V3. So as long as the T-wave inversions are present in V1, V2, V3, the T-wave inversions are not terribly deep, and they are limited to V1, V2, V3 in women, then that can be a normal variant as well. We've talked about that before, so if you go back to the website, www.ekg.umem.org, our residency website, and just go down to the search feature, you can look up the juvenile T-wave pattern, and you will be taken right to the video. I forget which week it was we talked about this, but it's a normal variant, this persistent juvenile T-wave pattern. Young women with T-wave inversions V1, V2, V3, completely normal. If they are, there's a few criteria there that you'll have to go to the video to get. All right. So number 3, we of course worry about cardiac ischemia or prior infarction or reperfusion. If somebody has a STEMI and they start to flip their T-waves in the first few hours, that's a sign that they are reperfusing. That's actually one of the things that you hope to see when you give thrombolytics to a patient who's having a STEMI. So new T-wave inversions in the presence of a STEMI can be a kind of a good sign if they are reperfusing. You may also see T-wave inversions all by themselves as a sign of ischemia, or they may be residual from a prior infarction. So this is what we normally worry the most about. T-wave inversions may be a sign of ischemia. T-wave inversions can also be a normal part of LVH. We refer to that as LVH with strain. Essentially, if you have a condition which produces abnormal repolarization, you can have flipped T-waves, and usually those T-wave inversions tend to be asymmetric, okay, as opposed to the symmetric T-waves. If you see symmetric T-waves like that, that's bad, okay? If they are asymmetric, that oftentimes is okay. That's what we refer to as LVH with strain or LVH with repolarization abnormality. Patients with high left ventricular voltage can have T-wave inversions. Patients with left bundle branch block pattern will have T-wave inversions in some leads. Patients with WPW can sometimes have T-wave inversions in some leads. So anything that screws up repolarization can produce T-wave inversions. Intracranial events, strokes, intracranial bleeds, cerebral edema, these can all produce T-wave inversions. In fact, in general, CNS problems can do just about anything to the 12-lead EKG. T-wave inversion is certainly a very classic abnormality. We'll talk more about that. Chronic cardiomyopathies can do it. Takotsubo cardiomyopathy, hypertrophic and dilated cardiomyopathies can give you T-wave inversions. Those usually are not new abnormalities. PE, we've talked about that before. You can use the search feature to find cases of PEs where T-wave inversions are present, especially in the inferior and anteroseptal leads. And other pulmonary diseases can do this as well. There's reports of pneumonia flipping your T-waves. And I recall reading one report where they said that if you simply hyperventilate, you can flip your T-waves. Don't try that at home, but it can actually happen. And then hyperkalemia, right? Hyperkalemia, the syphilis, or the great imitator of electrocardiography, as I like to call it. Hyperkalemia can do anything to the 12-lead. It can flip your T-waves. And hypokalemia can do it as well. Severe hypokalemia has a tendency to produce sagging T-waves, and then you get that big U wave. And so severe hypokalemia can give you that appearance, and that's a flipped T-wave, and then that's a U wave. We've gone over that before as well. And once again, you can use the search feature to check that out. But of course, the biggest thing that we worry about with flipped T-waves is still that ischemia or infarction. But it's important to remember that there is a handful of other things that can produce T-wave inversions as well. I don't have a good mnemonic. I think this is something that you'll learn and you'll remember just by going over case after case after case and learning these things with time and practice. But I think if you're going to remember anything from this list, you've got to remember number 3 and you've got to remember number 1 so you don't overcall T-wave inversions when you see them. Okay, enough about T-wave inversions. The other thing that we talked about on that 12-lead was a prolonged QT, and this is another thing that you can use the search feature and find. We've gone over prolonged QT on a number of different cases before. There's a bunch of things that prolong the QT. There's hypo-K, hypomag, hypocalcemia. So all of your hypoelectrolytes can prolong the QT. A lot of different medications can do it. And then a handful of other things. Elevated intracranial pressure, acute coronary syndrome or cardiac ischemia can prolong the QT, hypothermia, and then by default, if you don't come up with any of the above, hereditary things can prolong the QT as well. So looking at this list and also looking at the previous list, there's a couple of things that seem to be popping in for both. So hypokalemia showed up on both of our lists. Cardiac ischemia showed up on both of our lists. Elevated intracranial pressure showed up on both of our lists of differentials. Now, I'll tell you what, acute coronary syndrome doesn't typically produce much of a prolonged QT, just a little bit of a prolonged QT. And if you go back to this 12 lead again, this was a fairly pronounced prolonged QT. So I'm a little bit less concerned about the prolonged QT there. From acute coronary syndrome. So I'm going to take a little liberty and cross this off. So these are the two things that I'm most worried about: hypokalemia and elevated intracranial pressure. Now, maybe we can narrow this down a little bit more. With hypokalemia, usually you get a sagging T wave and then a giant U wave, and that's not something that we saw on that 12-lead EKG either. And this is a person that was found down. And so things really seem to be pointing towards that elevated intracranial pressure or CNF problems. Let's talk more about elevated intracranial pressure and CNS events. You could certainly make an argument that this is another syphilitic condition on EKG. What am I talking about? Well, let me say that another way. You can make an argument that this is another condition which is a great imitator on electrocardiography. Just like hyperkalemia, brain problems can do all kinds of wacky things to your EKG. Diffuse T-wave enlargement and inversions, Brady's and tachydysrhythmias, non-specific ST changes, ischemic ST changes. I've seen CNS events and strokes give you ST elevation, ST depression. Gosh, it can look an awful lot like a true STEMI. So CNS events can do all kinds of things. Hyperkalemia can do all kinds of things, and so on. So anyway, going back to the 12-lead EKG again, the two things that we went through on our differential that really stand out were hypokalemia, and we kind of got rid of that because there's really no U waves on this. So that really points towards elevated intracranial pressure. And that's exactly what Giuliano said. When this patient showed up, he took a look at these roller coaster T waves, and he said, I'm pretty sure this patient has a head bleed or something bad going on in the brain. The trauma team didn't know what he was talking about, but if you know EKGs, sometimes you can make diagnoses even before the pan scan and the white count, of course, that the trauma team probably wanted. And that was the CAT scan. No surprise to Giuliano. There's a big head bleed, maybe a mass right there, but a big head bleed and a huge amount of mass effect. This patient's brain is being shifted over quite a bit. And my guess, I don't know the outcome, but my guess is that the outcome was not all that great. But this patient did give us a great teaching point that we can learn from and help other patients with. So, quick take-home points from a very interesting EKG. CNS events can produce many abnormalities on the 12-lead EKG. We talked about that a couple of slides ago. And also, just a really nice, quick diagnosis can sometimes be made when you see these roller coaster T waves, the big T-wave inversions with the prolonged QT. When you see those T-wave inversions with the prolonged QT, that's actually been reported oftentimes in the EM, well, maybe not the EM, but in the cardiology and the internal medicine literature, and with slightly increasing prevalence in the EM literature as well, when you see those big gigantic T-wave inversions in somebody with an altered level of consciousness. So these are not people that are wide awake and alert. These are people with a decreased level of consciousness plus roller coaster T-waves. You're pretty much done. That patient has elevated intracranial pressure, oftentimes from a head bleed, and you can look like a star making the diagnosis an hour before the CAT scan and all the rest of the things come back. Just a quick 12-lead EKG, and you've got your diagnosis right up front. So my thanks to Giuliano for sending a really great case, and I hope that case was helpful. Remember, you've got to be the best at reading EKGs in your house of medicine, and if you can read EKGs well, you can make diagnoses much, much faster than oftentimes a big-time workup will give you. So I hope that was helpful, and I look forward to talking to all of you next week. Bye for now.